Last one. Woo. It's a brief whistle-stop tour through the wonderful world of gynaecology. I thought I'd start out with presenting some of our data from cases. So you can see that actually the vast majority of referrals that you make, we pass on through to secondary care. And the ones that we do pass back, it seems to be more that we're either giving you advice or we're asking for things. But mostly we're giving advice. So what are the main reasons that GPs in Sheffield refer to gynaecology? Biggest one is menorrhagia, intramenstrual bleeding. Second is pelvic pain and endometriosis. Other, I've never been able to get to the bottom of. HRT, prolapse, vulval disorders, smears that we can't do in primary care, ovarian cysts, postcoital bleeding and fertility referrals. What do we send on to secondary care that we can't sort out in primary care that the cases GPs can't give advice about? Menorrhagia and IMB, because as you know, at some point they're all going to need hysteroscopies and we can't do those in general practice. Pelvic pain and endometriosis is a really difficult one, particularly given the current political nature, shall we say, of endometriosis. Patients quite rightly want a diagnosis and it's difficult to say no. Prolapse, vulvar disorders, HRT, la. What do we send back with advice? Other, which, like I said, I've never managed to get to the bottom of, HRT, menorrhagia, fertility, PCOS, some pelvic pain, some postmenopausal bleeding, polyps, prolapse, and Mirana's or Pipel's. So, the fertility one, unfortunately, through cases, we cannot pass referrals through to assisted conception. Unfortunately, and I've had extensive correspondence, you have to use the fertility pro forma. If they've already been through the fertility sort of roulette, I don't know what you call it, you can write directly to Jonathan Scull at the assisted conception unit for advice, but essentially it needs to go directly to them. Everybody's eligible to be referred, even if they don't fit the criteria for assisted conception. And I would strongly advise you, if you've got a patient who doesn't fit the criteria to get free NHS treatment, you refer them anyway, because actually sometimes they'll give them a go on clomiphene, and that doesn't necessarily cost the patient. There are things that can be done, so I wouldn't put a bar at that point. Let secondary care put a bar if it's needed. They can be referred after a year of intercourse, even if they won't be seen because the waits are such a long time. They do need to go as a couple, and they do need to go through the ACU. Early referral is anything that might cause them to have pathology, and these people can go up almost instantly. So if you've got somebody who you know has got something like PCOS, they haven't been trying yet, you could get the referral stuff all done, all those hideous investigations, and be referring them. And if they get pregnant in the meantime, happy days. And if they don't, they're already there. BMI is a really difficult one. They will see them up at the Jesset wing, although I understand some of the consultants are more diplomatic than others. But they won't get any treatment until they've dropped their BMI. And that's the bottom line. Personally, because I'm a bit of a wimp, I would probably refer them up and let secondary care be the bad guys. In terms of if they've got a gynae issue, so they've got painful sex or pelvic pain or menorrhagia, we get a lot of referrals through cases where the couple want to find out what the problem is before they get pregnant. What you need to determine, what would really help the couple, is to get them to find out what their priority is. Because unfortunately, there usually isn't a magic gynecological treatment that we are hiding that will not affect their fertility. So if they want to get pregnant, they need to go to assisted conception. If they're not that fussed, they can go to gynae. There's no through route between the two things. They're not going to get seen faster if they go to gynae. Assisted conception will sort out their gynae problem if they need to, if that's going to affect their fertility. So overall, if they've got a gynae problem and they're desperate to get pregnant, they're better off going to assisted conception than going to gynae first. Recurrent miscarriages, they need to go to recurrent miscarriage clinic. We can pass that through cases. I'm mentioning it mostly because this vaginal micronized progesterone is a new thing, and you just need to be aware that patients will, so a patient came to me with the printouts, but patients may be wanting this, and it's important to know that it's an option these days. But discuss it with gynae on call. Heavy menstrual bleeding, top tips. I'm seeing increasing numbers of women who are reluctant for one reason or another to use hormonal treatment. And so they're getting referred to gynae because obviously you can't just continue to bleed indefinitely. Remember NSAIDs, remember tranexamic acid, remember that mefenamic acid is blacklisted in Sheffield. No matter what patients may say, we cannot prescribe it, and secondary care shouldn't be prescribing it. So ibuprofen is about 50% reduction in blood loss. It's always worth giving it a go. If you need to do that whole kind of slightly magic, a prescription placebo thing, naproxen is fine. IUS is the first line hormonal treatment. It can be fitted in the hubs. And as Mary Connor said 5 years ago, long course progesterones are more effective than short course, so ignore the BNF and use those regimes. Just so you're all aware, the current gynae waiting times, I have it hot off the press, are 50 weeks for general gynae, 55 weeks for menopause clinic. Conversely, the community hubs run by PCS, and I don't know what it's like in your own practices if you subcontract, we've got an average wait of about 4 weeks. Now, the community hubs have been an interesting thing because they are only commissioned to provide procedures, not to provide consultations, which is why, unfortunately, the referral forms are the way they are. They will do an IUS fit for menorrhagia. They will do Pipelles in high-risk women with regular periods. They will do an IUS fit for endometrial protection for HRT, ring pessary first fits, and cervical polyp removals. So you may have seen sometimes that the cases GPs will send you advice back saying, do you know what, it might be better for your patient if you sent them to the community hub, just because it's probably preferable to wait 4 weeks and get some treatment than to wait 50 weeks bleeding the whole time or being in pain or whatever it happens to be. However, thanks to Lindsay Thomas, stand up Lindsay, and her persistence, we have managed to get funding for a community women's health hub which will offer consultations. We've only got it for a year and we need to prove that it works. It's going to be co-located with the existing hubs in the hope that that will help to streamline the patient pathway. At present, the way that into the patient pathway is you refer your patient into gynae as you would do ordinarily through cases, and then if any of the cases peer reviewers think that this is a patient who would be suitable for the community clinic, we will tell you and direct them to the community clinic where they will see Lindsay and hopefully be seen an awful lot faster than they are in gynae. Patients will still be referred to secondary care. We're not going to divert everybody through. And if you have a big objection to them being seen in a community clinic by Lindsay and you would rather that they wait 55 weeks, that's fine. You can still do that. And what will we see? Mostly HRT and menopause, because that seems to be the thing that one of the things that we can do something about in primary care that is easily sortable, that will reduce the waiting list STH. So hopefully this will benefit everybody. Lindsay, we've had a bit of a debate about testosterone. Lindsay will prescribe testosterone. She's written an excellent shared care thing. But again, it would be dependent on the GP who was referring being happy to continue that prescription. And that will be something that will be discussed if it comes to it. And then we'll discuss the options for heavy menstrual bleeding because, like I said, at the minute, the hubs, it's you have a Mirena or you go back to your GP, but we might be able to have a bit more of a discussion. There is some new guidance on the press portal, which comes from the South Yorkshire ICB, unscheduled bleeding. It doesn't change the 2-week wait criteria, but you need to be aware because it slightly contradicts the recent BMS RCOG guidance. Our gynaecologists are working to this pathway, so you may find that if you follow the BMS pathway, you'll get referrals rejected. So it's just being aware that there are differences. The BMS RCOG guidance goes faster to 2-week waits. If you're requesting an ultrasound scan, I've been informed by one of my registrars that you know when you do the drop down and it says routine urgent, and there are some funny numbers at the top which I can't quite recall. That's the one. Apparently they mean that you really think it's cancer and they'll get faster. Who knew? But apparently it works. But in any case, if you put in the referral criteria that it's within 6 weeks, apparently that helps too. But essentially these patients should be being scanned within 6 weeks. Lindsay has written this brilliant summary of PCOS on a slide. So I'm not going to run through it, but it's there and you'll get the slides. And the main reason I'm mentioning that is because there are some brand new guidelines in 2023 regarding PCOS and its diagnosis. You can now make the diagnosis if they have irregular menstrual cycles and they have spots or they have hirsutism. You don't need to do bloods necessarily, and you definitely don't need to do a scan if they're an adolescent. And then I put this up mostly because I found it quite interesting. So essentially it's normal in the first year of post-menarche to have irregular menstrual cycles. And it's also normal up to 3 years. And they don't consider someone to have reached menstrual maturity until they are 8 years post-menarche. So you can't really diagnose anyone as having PCOS until they're 8 years post-menarche. So I thought that was interesting because, again, it depends on what age they start their periods at. So if they start younger, you might expect them to reach menstrual maturity earlier, and if they start later, then you could be mid-20s before you can confidently say someone's got PCOS. So these are the bloods. Oh, the main thing to know in the bloods is that if they're on their combined oral contraceptive, they need to be off it for 3 months before you can do them. And ultrasound we only do for grown-ups. Don't do them for teenagers. They'll get diagnosed because they've got lots of follicles because of the menstrual chaos. So the guidelines are suggesting that we don't just abandon these girls with their irregular periods who are perhaps a little bit overweight, whose mother may have PCOS. We consider them to be at risk, and that we reassess them when they're 8 years post-menarche. They seem to be suggesting that we give them a combined pill to treat their periods, but we don't need to investigate any further. And again, if they're old enough to bleed, they're old enough to have a combined oral contraceptive. So don't have any particular... Again, we get occasional things where GPs are a little bit reluctant to prescribe in the very young, but they're better off having a combined oral contraceptive and being able to get on with their lives and not having misery at school. And I don't know how many of you have got secondary age kids, but secondary schools are very tight about letting kids go to the toilets. And so you just don't want these poor girls flooding their way around school. So put them on the pill. Endometrial hyperplasia, it's not just the overweight who are at risk. Anyone who's got PCOS is over risk. So you need to think about it in all of them. Even if they're slim, they still need to be having their regular bleeds. And this is endometrial thickness. And if women are unwilling to take cyclical hormonal treatment or use a Mirena, you can regularly scan them. And it's a pain in the neck, and it's not very brilliant, And it is rubbish that they're going to have to take hormones, but unfortunately, this is all we've got. And I think that's probably the only way to have the conversation with the person. One of the things that we commonly get is when you've got ladies with PCOS who are overweight and who need contraception and endometrial protection. Ideally, they would use a Mirena or equivalent coil. If not, we think the depot will suppress their endometrium sufficiently that you don't need to worry. And I emailed the CEU of the FSRH, and they think that if you are amenorrheic and on a progesterone-only pill, you don't need to do anything else. Their endometrium should be thin, and we don't need to make them have bleeds on top of that. So the only people we might worry about with PCOS on a POP are the ones who are having irregular bleeding. And then this is a really depressing slide because basically there's no magic bullet for weight loss and PCOS. There's nothing commissioned, and they're going to find it more difficult, and their hormones will make it more difficult for them to lose weight. It's not their fault. And so anything you can encourage them to do is better than nothing, but there isn't, again, a magic bullet. Metformin. So a lot of women are very keen on metformin. Metformin is something we prescribe a lot in general practice. It's worth a go. It's, again, not a magic bullet. The evidence is conflicting. It may help with weight loss. It may not help with weight loss. It may help with cycle control. It may not help with cycle control. The bottom line is, if the patient is very keen, give it a whirl, but you still need to think about hormonal methods to control their bleeding and make sure that their endometrial thickness, it's not good enough by itself. And that's it. And I got through that rather fast. I put some references, and please do the feedback.